right. So thank you everybody for joining. We're here at 5:30, so we'll go ahead and get started. Today with me, I have Graham Kimmer. He is a senior strategist with MFS Investments. He's been in the industry since 2010. Pretty much all of those have been with the MFS since 2013. So previously, before that, he was an advisor. So he has sat in my shoes. Has had the conversations, the same ones that I've had with you about Medicare, when to enroll, what types of policies to get, who to try to talk to, things like that. And now he gives these presentations, I would say almost weekly, and is going to be a great wealth of knowledge for us, or maybe sometimes twice a day. I don't know, right? So, outside of the office, Graham trains for long distance races, lives with his wife Katie and their Basset hounds. Yes, multiple. And then he's out of West Boston in a historic home. So I'm sure that's very fun to try to keep up with. So with that, I'm going to tee it up to Graham. And if you guys have any questions, feel free to either unmute yourself and ask them, or we're going to have a Q&A here at the end as well, where Graham will be able to chime in, answer any questions you have, as well as Kevin Loudon with RetireMed, who is a local resource here in the Dayton, Ohio area. So with that, Graham Kimmer, take it away.
Thank you so much. Much appreciated. Thanks to the entire Feldmeyer group for having me a part of the conversation tonight. But most importantly, thank you all for joining in to have this conversation around Medicare. Normally, one of the things you'll find out in the wild when it comes to Medicare is this handbook that the government issues called Medicare and You. If you've seen it, you'll know it's pretty thick. It clocks in at 128 pages and just shy of 50,000 words. To give you an idea of how long that is, a novel needs to have 50,000 words. So this is what the government issues you is basically a novel length handbook for you to figure out what's important for you when it comes to your healthcare throughout the entire course of your retirement. And we do know that Medicare can be a very confusing and very complex topic. But what I'd like to do with our time this evening is to uncomplicate that a bit for you. What we're going to do first is go over original Medicare. This is what the government offers you, Parts A and Part B. So we'll talk about what it is, costs, and is not. Then we'll talk about additional plans that you'll likely want to consider. Part D plans for medications, Medicare Advantage plans that are also called Part C plans, and then Medicare supplement plans, which are also called GAP or Medigap plans. And then we'll wrap up with the when question. When it is that you need to apply to get the timing right and also to avoid any costly penalties. But up first with original Medicare, just want to quickly let you know how you qualify because it's pretty easy and it looks and feels a lot like Social Security. You need to work and pay your Medicare taxes for 40 quarters. Those quarters don't need to all be in a row, just need to have 40 of them all put together. If you yourself don't have those, as long as you are married to someone or you had previously been married to someone for 10 or more years, that'll qualify you as well. Generally, you need to be age 65 or older in order to first enroll. But there's a couple of instances where you could get in at a younger age, but it involves disability. If you're on Social Security disability insurance for 24 consecutive months, you can then qualify in the 25th month. Or if you have end stage renal disease, which is kidney disease, or ALS, more commonly called Lou Gehrig's disease, if you qualify for Social Security disability with either of those two illnesses, you'll then immediately qualify for Medicare with no waiting period. And Medicare has an enormous network. Most doctors in America participate as part of the Medicare network. The first portion of original Medicare is Part A, and this is usually referred to as hospital insurance, but it covers a lot more than just going into the hospital. It can cover up to 100 days in a skilled nursing care facility after a qualifying stay in the hospital, inpatient nursing care, home health care, and then hospice care as well. Jimmy Carter was on hospice care for nearly 2 years at $0 per day cost to him. And that wasn't because he was just a former president. That's just the kind of hospice coverage that comes along with Medicare. You'll notice in the parentheses, though, it says not long term care or custodial care. So if anyone you know may have custodial care needs, that's actual help doing daily activities, Medicare will not help pick that up. Or if folks are considering going into long term care facilities, Medicare will not pay for any of the room and board. And depending on the facility itself, maybe just a portion of any treatment that you get. And these facilities can be very, very expensive. So you want to make sure you're at least budgeting appropriately, or maybe seeking other forms of insurance that can help offset the cost of stays in those facilities. In addition to being called hospital insurance, Part A is usually referred to as premium free Medicare. And for most individuals out there, that's completely true. You are unlikely to pay a month over month cost or a premium for your Part A coverage. But there is cost for any of the treatment that you get. As most folks experience Part A by going to the hospital to start, that's what I want to take a quick look at here. The first important factor to know is that you do need to be admitted as an inpatient. So you're not just going to the emergency room, you're not there overnight for observation. You need to be officially admitted as an inpatient. Once that happens, it sets off what's referred to as a benefit period. Benefit periods last for 60 days. So if I go to the hospital on January 1st, I'm there for a week, I get discharged, and I go again on February 1st, I'm inside one benefit period. But if it's January and then again in August, it's going to be two separate benefit periods. But once that period opens, a deductible has to be paid. For this year, that amount is $1,676. And then following that, Medicare Part A will pick up the first 60 days of your explicit hospital stay costs. If you're in the hospital for days 61 through 90, it's a $419 per day copayment. And if you get to day 91, then you'll start using up what's referred to as your lifetime reserve days. We all have a bank of 60 of these. Once they get used up, they don't get replenished. While you're using them, that copay doubles to $838. And then if you're in the hospital for a very long time, 150 or more days, or if you've used up those lifetime reserve days and you have another long hospital stay, then you'll have to pay all the costs associated with your hospitalization. I do this presentation about 300 times a year, and I have not had a single taker for people that want to be in the hospital for 60, 90, let alone 150 days. And I sincerely hope that happens to absolutely none of us. The second portion of Original Medicare is Part B. Part B covers outpatient services not specifically related to a hospitalization. So it's usually referred to as doctors or medical insurance. Part B covers preventative services, things like x rays, CAT scans, MRIs, mammograms, things of that nature. Emergency room visits are covered under Part B, not Part A, because this isn't considered an inpatient setting, along with urgent care. Durable medical equipment is a big component of Part B. That's going to be canes, walkers, wheelchairs, hospital beds, but it can get really specific. It can be things like insulin pumps or blood test meters. What qualifies for durable medical equipment is an extremely long list. And then in limited capacities, Part B can help cover some prescription drugs, some clinical research, and oftentimes combined with Part A, elements of mental health care. Unlike with Part A, there will be month over month costs or premiums you have to pay for your Part B coverage. If you look at this middle blue column, these premiums start this year at $185 and climb to nearly $630. This is called an IRMA. IRMA stands for Income Related Monthly Adjustment Amount. And although it sounds like my friendly Aunt Irma, it really isn't. It can not only be very costly, it takes a lot of folks by surprise. The reason for that surprise factor is that these premiums are based off of your modified adjusted gross income and your tax filing status from 2 years earlier. So let's just say that I'm age 65, I'm retiring, I'm enrolling into Medicare. They're looking at when I was 63 and still working to determine what these premiums should look like. So for a lot of folks, their best, if not their best years, are leading up towards retirement. So they could find themselves starting off in a higher IRMA premium level. And a lot of times, we just assume that's the government, we're going to have to pay them. You may not have to, however. If you've had a major sustained life event and your income moving forward after filing for Medicare is lower than it was leading up, you can petition Medicare to lower these premiums to the more appropriate level. There's a form you use called SSA 44. That's SSA, like the Social Security Administration, dash 44. If you've retired, what they officially call a work stoppage or a reduction in work. That's the most often used version of this. But also, if you go through a divorce, potentially if your spouse predeceases you, the loss of pension income, the loss of an income producing property not through a sale or a transfer. If any one of these activities occurs and puts you below one of these brackets relative to what it was leading up, you can then fill out that form and make sure it gets assigned to the more appropriate level. You'll want to wait until you get the official letter that says what your premium would be to fill out that form to make sure it doesn't get lost in the ether, but then you're able to have that reduced to the more appropriate level. You need to fill that out not just for the first year that you're on Medicare, but also the second, and this is per person, not per couple. So even if you and your spouse were enrolling in Medicare on the same day, you would both need to fill out your own SSA 44 form. And there is a second surprise factor to this as well. Because if certain actions take place, you might see your premiums increase 2 years later. For years and years and years, I talked about Social Security exclusively. And one of the questions would pop up sometimes, which was, why did my Social Security check go down? Because if you're both on Social Security along with Medicare, you're going to have your Part B premiums automatically taken out of your benefits. But what in reality, it's not that their check went down, it's that something happened that caused their increase in a Part B premium. And we'd ask a couple questions and find out they might have downsized their primary residence. It's outside the exclusionary value, that extra gain gets added in. The sale of a rental or a vacation property, that would get included. The sale of another major asset, big capital gains in a given year, doing Roth conversions, the exercising of stock options, all of these actions 2 years later could increase your Part B premiums. So you'd want to make sure that you're working with the folks over at the Feldmeyer Financial Group to understand not just what the premiums look like leading up and to maybe help you plan around them all together, but to also understand any of the potential knock on effects that could occur even well into retirement. Aside from the Part B premiums, there's also just general cost for Part B coverage. There's a pretty low deductible. It's $257 for this year. And then following that, Medicare pays 80% of the approved cost for Part B. And then we're on the hook for the remaining 20%. Approved cost is a bit of a tricky phrase, though. There are a lot of doctors out there that accept what's referred to as assignment. Assignment means whatever the Medicare approved amount is, that's the total billable cost. So if I go see a doctor that accepts assignment, cost is $100. Assuming I've paid my deductible, Medicare pays 80, I pay 20. Some doctors though don't accept assignment. They can legally charge up to 15% more. So that become 115 in our easy math example. Medicare is still only paying the original 80, but I'm on the hook for 20%. So as you're enrolling into Medicare, particularly Medicare plus a gap plan, which we'll be talking about in just a few minutes, it can literally pay to ask your doctors whether they accept assignment or not. So that way there's no surprise cost of treatment for the doctors that you want to see. And Medicare A and B, what the government offers you, it's an enormous program. We have barely scratched the surface of all the different treatments and procedures that Medicare can assist with. But there is some everyday healthcare that we get used to that isn't covered. Routine dental, vision, or hearing isn't going to be covered. Routine physical exams, like a yearly, every year physical, not going to be covered. Care outside the United States, unless it's a very specific emergency on the border of Canada, that's not going to be covered. So to me, it's a bit like if you're going car shopping, part A and B is the base model. It gets you rolling down the road, but it doesn't have all of the features that you'll want for your healthcare and retirement. So that's where additional plans can come into play. The first I'd like to go over is a Part D plan for prescription medications. Even though this has that letter D, this isn't offered through the US government. This is offered through private independent insurers. And the reason why I want to bring this up is that once you retire, even if you're on zero medications, the government requires you to have what's referred to as creditable drug coverage. If you don't, they'll penalize you for each month that you should have. So it's definitely worthwhile to have a very basic plan that even just checks the box to make sure that you're not incurring any of those penalties. But you're going to want to write down a list and compare any medications you're on to what's called a plans formulary. Formulary is just a very fancy word that means list of medications. It's what the plan assists and helps pay for. So that'll vary plan by plan. Usually they assign these medications into one of five tiers. The lower tiers are going to be generic or low cost drugs. You might have small, maybe even sometimes no copays for those medications. But the higher tiers, name brand, specialty, more expensive medications, you'll wind up shouldering a higher percentage of that cost. There are IRMAs for Part D plans as well that gets attached to your regular Part D plan premium, and your premiums will vary plan by plan. And a best practice is to review these plans annually. We are knocking on the door of that review period. From October 15th through December 7th is what's referred to as the Medicare open enrollment period. But it's not really all of Medicare. It's really the review period for folks that are already enrolled in Medicare that have made the choice for Part D plans as well as Medicare Advantage plans to take a look at that coverage, see if any meaningful changes have occurred for their plans, decide to stick with them, or pick new plans for the following year. Part D plans, how we pay for them, got a lot more simple this year. It's probably one of the biggest changes that occurred to Medicare overall. It used to be a lot more complicated, but then now there's just what they refer to as phases. There's two phases that we need to move through. Phase one is the deductible phase. The government has capped this at $590 for this year, $615 for next year, but some plans will have lower or maybe even no deductibles, but they'll credit this amount. Then phase two is the coinsurance or the copayment phase. If more than $2,000 is spent, and this is not just your contribution, this is the plans as well, then you won't have to pay any more money for covered medications. But again, that is the key word. It does need to be a medication that's a part of that plan's formulary. If you get assigned a new medication in the middle of the year, you may be having to pay out of pocket costs for that. No surprise, in the United States, medications are not particularly cheap. Or sometimes you can get what's called a formulary exception, which means the plan will help you pay for it for the duration of that year, but then you still need to pick a new plan for the following year that's more appropriate for you. Following enrolling into Medicare Part A and Part B, and I do promise we're going to talk about in that enrollment period next, folks generally go in one of two different directions. They either go the direction of a Medicare Advantage, also called a Part C plan, or a Medicare Supplement, GAP, or Medigap plan. I'm going to start on the left-hand side where it says Medicare Advantage or Part C. And again, that letter C, even though it's got that letter, it's not the government, it's through private insurers. And Advantage and C means the exact same thing. They are synonymous. If you're like me and you like watching reruns of Frasier at night, this is what Name Your Washed Up Celebrity is probably trying to sell you on those commercials is a Medicare Advantage plan. What these plans do, by and large, is privatize and replace Medicare. It becomes your healthcare coverage. They share a lot of similarities with group healthcare plans you usually have when you're working. They have a Part A component, so hospital component, a Part B, a doctor's component. Many of these plans will have prescription medication plans incorporated in, and they can have some other benefits or features. Think things like gym memberships, the Silver Sneakers program, premium rebates. The list of features for these plans varies plan by plan, network by network, area by area. The network will also be different. It's not the Medicare network. It's going to be a network that's specific for the plans, usually falling into one of two categories, either an HMO, a health maintenance organization, which is pretty local, or a PPO, a paid provider organization, which has both in and out of network pricing. To go see specialists, you may need to have referrals to do so. And there's also what's called pre-authorization. Pre-authorization is a pre-approval process. So let's just say that I need to have knee surgery. It's not just my doctor that says, you need knee surgery that allows me to get that scheduled. I may need to get that pre-approved or pre-authorized from the insurer before I'm able to get that on the books. And I'm going to want to stay inside that network. And then there's going to be your traditional deductible and copay or coinsurance structure. These plans are also oftentimes referred to as premium free or low or no cost plans, which I think can sometimes be a bit misleading because the Part B premium we talked about before, including any of those IRMAs, you still have to pay those. Except rather than that going to the US government, the US government is offering a payment to the Medicare Advantage plan provider to take your healthcare off the government's table and put it onto that insurer. If you go see a doctor, you don't use your red, white, and blue Medicare card. You use a card that comes from the Medicare Advantage plan. So again, a Medicare Advantage plan privatizes, replaces Medicare. It becomes your healthcare under one big umbrella. Many of these plans will also incorporate in dental, vision, and hearing, so it is feel an awful lot like the plans we have while we're working. On the flip side is what's called a supplement, gap, or Medigap plan. And I'll apologize in advance if you are sick of letters, more get thrown your way here. If you've ever heard of Plan G or Plan N, those are gap or supplement plans. There are right now 8 standardized letters. These are all federally standardized that are available in most states. If you happen to be in Minnesota, Wisconsin, or Massachusetts, where I live, they have their own state specific rubric for plans, but they work very, very similarly. What these do, as the name implies, is fill in the gaps and supplements what original Medicare does not. So this works in tandem with Medicare. Medicare Part A and Part B becomes the foundation of your insurance. You can then choose a gap plan. You do have to pay an additional premium for a gap plan, but what do you get for that additional premium? It could pay the Part A deductible, could pay the Part B copayment, the overage for doctors that don't accept assignment. There can be an international travel limit, extra blood if you need to get that. So it can help control a lot of back end costs, the trade off being that additional premium that you do need to pay. It is a bit of a do it yourself method to start because it's Part A and B from the government, the gap plan letter that you choose, a standalone prescription plan, and then if dental, vision, and hearing is important for you, you can get your own insurance there as well. Or sometimes doctors, most oftentimes eye doctors and dentists might have clubs that you can join. They'll give you discounts, or there might be a pay-as-you-go rate. The network with gap plans is Medicare. So even if you were to have a plan issued in Ohio and you are visiting family in California, it'll be accepted. There's rarely referrals for specialists, and the incidence of needing pre-authorization for supplement plans or gap plans over Advantage plans is very, very small. One of the catches is that if you want to get a gap or a supplement plan with what's called a guaranteed right of issuance, that means no questions asked, you're going to get that policy written for you. You usually need to pick a gap plan within 6 months of first enrolling in Medicare Part B. And that includes the state of Ohio. They default to their regular 6 month window. You need to pick that. If you're outside that 6 month window, you could go through medical underwriting. This means pre-existing conditions could become known. At worst, which is really rare, they can deny you the policy altogether, or what they'll usually do is increase those month over month premiums. So this leads to the last topic we have before I hand this back over to Derek, which is when it is that you need to apply. There are 5 different enrollment periods that correspond with Medicare. The 2 that matter the absolute most for you when you're getting started is either going to be an initial enrollment period or a special enrollment period. So for the sake of time and your sanity, that's what we're going to focus on here this evening. The initial enrollment period, or the IEP, is for when you're turning 65. What we need to know is, are you planning on continuing to work past 65 with your own company's group healthcare plan, or will you be on a working spouse's group healthcare plan after 65? As long as that company has 20 or more employees and the coverage is considered creditable, that means you don't have to enroll into Medicare at all. Neither Part A or Part B. You don't need to alert Medicare that you're not doing this. You simply don't enroll into Medicare, and you'll do that later, talk about next. However, if you no longer have coverage or you're not covered by a spouse, you need to use your initial enrollment period. This is a 7 month window that surrounds your 65th birth month. It starts 3 months before, it includes that entire month, and then it extends up to 3 months afterwards. If you do the 3 months before, it starts on the first day of your 65th birth month. If you do that month or any of the 3 months following, it then starts the first day of the following month. Even if you were born on the middle of the month, it'll always start the first day of a month. Couple other considerations though. If the company you or your spouse work for is smaller, less than 20 employees, so 19 or fewer, that coverage, no matter how good, no matter how expensive, pays secondary to Medicare. That means Medicare becomes your primary biller, primary payer, and that plan will only pay secondary. So you would need to enroll during your initial enrollment period. If you were on COBRA benefits leading up to 65, or your company offered you retiree benefits, that means you stay on the corporate plan even though you're no longer an active employee. That works the same way. You still need to enroll during your initial enrollment period. The other catch is if you have a health savings account, an HSA, that you're continuing to contribute to. And this is because a lot of folks are sometimes told they have to or are encouraged to enroll into Part A when they're 65, even if they have a group healthcare plan because they're continuing to work. And I think that's good advice, but not always great advice. And here's the reason why. If I'm continuing to work past 65, I'm actively contributing to a health savings account. If I were to enroll into Part A, I'm then in violation of a whole bunch of IRS rules around high deductible healthcare plans. I lose the tax deductible nature of my HSA, and there'll be later tax penalties as well. So, if having that HSA is important for me, I would not want to enroll into Medicare Part A at 65. If you know you don't have an HSA, you want to stop funding it, you can enroll into Part A at that point and still hold off on Part B. It's no harm, no foul, and it can help in the event of extreme hospitalization. If you did work past 65 or you were covered by a working spouse, but now that's all ending, then you enter into what's called a special enrollment period or an SEP. You can do this while you still have your group based insurance. So, 2, 3 months out, maybe. Once you lose your coverage or you retire, whichever happens first, and this extends up to 8 months afterwards. I'm personally not a big fan of that up to 8 month window unless this was a surprise event and you're figuring out a little bit of time for your next move because you could have holes in your insurance. If something were to happen, it could get very, very expensive. So, as long as you know what your game plan is, you can make sure you have not just Medicare enrollment lined up, but all of those other pieces of insurance. Two other pieces to consider here, though. The first still involves the HSA again. And for whatever reason, haven't been able to determine it, they will backdate your Part A coverage by 6 months just during your special enrollment period. So let's just say I'm 67, retiring, enrolling in February. They're backdating my Part A 4 months into the prior year, which means if I fully funded my HSA the year before, I may have inadvertently overfunded it, causing a taxable event. So as you know what your plan is going to be, you can work with your HSA provider to just fund up until the allowable limit or the allowable month. The other consideration is if you should have been on Part B. So sometimes folks think that their COBRA benefits would count. Now we know they don't. They thought their company had 22 people. Turns out there was only 18. For each full 12-month period, you should have been on Part B. Medicare will attach what they call a surcharge. All it really is a penalty. It's a 10% penalty for each full 12-month period you should have been on Part B. So that's only full 12 months. So if you go 14 months, it'll still only be 10%. They're not prorating it on that extra 2 months that you should have been. But if you wait 2 years, that's an extra 20%. And this gets attached to your Part B premium each month for the rest of your life. There's no way to appeal that. The good news is they're only basing this off that first level of Part B premiums. If you have an IRMA, it wouldn't be based off those increases, but still, it can add up over time. I am going to be pausing here in about 40 seconds to hand this back on over to Derek. But my ask of you all is to start this conversation early, not just when you're about to turn 65 or about to retire. We want to make sure you know what your game plan is going to be and that you're also involving your family because they will become very helpful as time goes on. You're going to want to work with a financial professional. And the good news is we've got them here tonight. I probably said the word cost 30 times in 26 minutes. Medicare is not cheap. The cost of healthcare in the United States has traditionally risen faster than inflation. We want to make sure this is part and parcel of your financial plan. You may want to work with a licensed specialist and agent, someone like Kevin, that can help you understand what plans you're available to for right now, and also help align other plans down the line when you do that review period every single year, because we always want to make sure that you have the right healthcare, not just when you start retirement, but throughout the course of your retirement. So I'm going to pause here. I'm going to take a sip of water. I'm going to hand this back on over to Derek.
Awesome. Thank you, Graham. I am going to go ahead and see if I can share my screen now, and then I'll hand it over to Kevin. While I am working on getting the screen all pulled up here, I'm going to introduce Kevin Loudon. He is a senior executive senior account executive on the business development team at RetireMed. He has been in the Medicare industry for over 13 years and provides presentations and educational information to the community where individuals who need information can rely on him, whether that's Medicare or individual health insurance. RetireMed is an advisory service group with offices in Blue Ash, Ohio and Dayton, Ohio here in town. They provide services to groups and individuals who need a resource for Medicare. Um, Retirement advisors work with individuals who need help as they consider the health insurance option as they become eligible at age 65 or prior to that retirement. So with that, I'm going to go ahead and hand it over to Kevin. Can you guys see my screen? Is that sharing?
It's sharing very well, Derek. Thank you.
Okay. And then Kevin, I have the controls, so feel free to just tell me when you want me to move it over to the next slide.
Yeah, and you covered a lot of it. So again, welcome everybody. And I appreciate the invitation this evening. As Derek said, we are a resource for folks in the area for both Medicare and individual health plans. So we kind of work on both sides of that 65th birthday. For people who are moving to Medicare at 65 or beyond, we will help you at that point. For those folks who are early retirees or maybe spouses of retirees who don't have other health options available to them, we can help with marketplace ACA plans as well. So again, as people who are 65 and retiring, moving to Medicare, for people who are 65 and continuing to work, Graham made a good point. There are a lot of decisions to kind of be made as you're approaching age 65 if you're going to keep working. We can work with you to compare your group coverage to Medicare and just kind of walk through the comparison process and the math, if you will, to help you decide whether Medicare is a better option for you going forward or whether your group coverage is. And we see in a lot of cases, Medicare really can be a better option than group coverage. Again, Medicare, to kind of echo what Graham said, is very much an individual decision. So that's kind of what we do. We are a no-cost service. There's never a charge to work with us. When I say that in these types of presentations, I always get the reaction, well, how in the world do you people stay in business if you don't charge for your services? And the answer to that is that when we enroll someone in a Medicare plan or an individual health plan, we get compensated by the insurance company. That will again raise the question, well, does Anthem pay you more than United Healthcare or MedMutual or whoever it might be? And the answer to that is no. That whole compensation structure is regulated by the government. So it's really a very nice win-win situation because we have no incentive one way or the other in terms of the insurance company we might recommend. Our whole mission is to make sure our clients are on the best plan for their particular needs. And Derek, I can't remember what I had on the next slide. Oh, there we go.
It's where you help people with those needs.
Yeah, I'm sorry. Yeah. So where are we? So again, we're headquartered here in Dayton. We have an office in Blue Ash, but we are licensed in Ohio, Indiana, Kentucky, Pennsylvania, and Florida. We have other states on the way. If you happen to be outside that geography, we've got a partner that we work with that we can typically recommend for people. We go through, and you can go to the next slide, Derek, a fairly rigorous research process with each person that we work with. So kind of alluding back to what Graham was talking about, we will talk to you about the doctors that you see, the prescription medications that you take, and that type of thing prior to meeting with one of our advisors. We try to get to know you and your needs and kind of what you're planning on doing in retirement or kind of what the next steps are in terms of what's going on in your life. We do all of the research for you. There are over 200 Medicare plan options available in the state of Ohio. So it is kind of one of those don't try this at home type things because it can get very, very confusing, very, very stressful. We will kind of make plan recommendations on both sides of the options. So we'll talk to you about Medicare Advantage plans and how those work, Medicare supplement plans and how those work. And then once you decide what's going to be the better fit for you, we help you through that enrollment process. We can help you through the process of enrolling in Medicare as well. And then something that we do that is somewhat unique in our industry is that this is not a one and done type situation. If you become a retirement client, we provide lifelong support. So that means anytime throughout the course of the year, if you have questions on your health insurance, you're not calling 1-800 who knows where and listening to bad hold music and pressing one for this and two for that. We have a team that's there to kind of advocate and answer questions for you and help you through any issues that might come up. That team is also there to help our clients every year during the annual enrollment period that, as Graham mentioned, we are coming up on very shortly here. So we help with plan reviews each year to ensure that people continue to be on the right plan, whether it's a standalone drug plan, a Medicare Advantage plan, because those plans can change each year. As a broker, we work with all the major health insurance carriers out there. So you've got kind of the full range of options available to you. You do have the ability, obviously, to go directly to the insurance company if you want to do something like that. But I will tell you, if you call Anthem, and they'll be happy to talk to you about a Medicare plan, but they're not going to suggest that you call Humana to see what they have as well. So we kind of can cover the waterfront from that standpoint. One other thing I wanted to follow up with what Graham said is, again, with the annual enrollment period that is coming up, it starts October 15th. In this area, at least within the state of Ohio, we are anticipating that this is going to be a pretty disruptive year as far as Medicare plans are concerned, especially with Medicare Advantage plans. There is a lot of churn from the standpoint of plan changes, network changes, changes to benefits in those plans. And so if you're currently on a Medicare Advantage plan or you know someone who is, we really strongly encourage that those plans get reviewed this year. I've been doing this for a while. I know that people get comfortable with the plans they're on. People are change resistant. I went through this with my mom and dad, and sometimes it's just tough to get them to look. But this is one of those years that it really will be worthwhile to do that because, as I said, there are a lot of changes coming up. And I think we can go to the next slide. So in terms of getting in touch with us, a couple different ways. You see the 877 number here. That will get you connected directly with our advisor group. They are there not only to help you with your Medicare plan decisions, but if you've got questions as you're approaching Medicare eligibility, everybody kind of has that know-it-all neighbor or brother-in-law that's more than happy to fill you in on all kinds of things. Typically, they're not correct. Give us a call. We're happy to answer those questions as you go along. The QR code that you see there will connect you to a site that you can enroll in our newsletter. It comes out once a month. It comes to your email. We try not to spam you with anything or anything along that line. Typically 4 or 5 articles directed at people within the demographic. So it's going to be not just Medicare information. It may be financial planning, retirement planning, personal wellness, kind of whatever's on tap that particular month. But it also will kind of keep you ahead of the game as far as Medicare education is concerned. And with that, I mean, if there are questions, I know Graham is happy to answer. I'm happy to answer, but I think that's where we are at this point.
Yeah, so I will ask anybody. First of all, I guess I need to take a step back and thank both Kevin and Graham for coming on here and providing so much knowledge. So it's great to get some of the detailed how it works from Graham and all the nuances of starting and stopping and what the different types of plans are, as well as Kevin knowing that he's a local resource here and can help walk you through the process to say, okay, it's great to know that there's all this information out there. Now, what do I do with it? Because I have no idea, right? So, Graham, I know that for the major sustained life event, right, where we're looking at those IRMA premiums, we've done it before where, clients have the higher income and then they go to a work reduction or retirement, and that's an easy one to submit. We've done it before. Is there any way around if their investment accounts cause that one-time like windfall, if you will, whether it was a one-time like large capital gain, Roth conversion, anything like that, where it's like We did this one
No,
time
generally
only, and
no.
okay.
Yeah, I hate to be the bearer of bad news. But yeah, unfortunately not. That just, it will, but it is just for that 1 year. It's not like it sets in stone, so to speak, that elevated premium for the duration of that year.
It's the answer we typically get, but I always like to ask it, right, to
It
make
doesn't
sure
hurt
if
to
somebody
ask.
doesn't know something that's not out there, right? And then if someone's using the Medicare Advantage plan, does that avoid any of the concerns with that IRMA limit? Or does
Not
that
really.
still impact their Medicare premiums?
So the Medicare Part B premium, whatever that determination is, whichever that is, even including an IRMA, that always needs to be paid. It's unavoidable.
Okay.
Medicare Advantage plans, many of them will have no additional premiums or just small ones. Um, but even though you have that Advantage plan and you're, not truly on Medicare and getting billed through Medicare, you still have to pay the Medicare Part B premium, which
Okay.
again
So
has been a confusion for a lot of folks when they say, "Oh, I signed up for Medicare Advantage plan. I was told it was premium free, but I'm still having my Part B uh, premium deducted from my Social Security benefit. What gives?" And that's the reason why.
okay. And then I know Kevin had mentioned, there's going to be a lot of changes, and this is especially in Ohio this year, a good reason to reach out. I would encourage folks, even if you already are on Medicare and you're comfortable with your coverage, or your parents or friends or neighbors say like, "Hey, I feel good. I'm just going to renew." Reach out to somebody, right, Kevin or somebody, but
Hmm.
we know who a local resource is, and they do great work. And just check, right? It doesn't cost anything to make
Right.
sure that you have the right coverage that you need. As people consider going back and forth, something to consider. Um, I don't believe that's something that you can flip flop back and forth between traditional and Medicare, right? Graham, do you mind enlightening us a little bit about that?
Yeah, it's not easy necessarily. I mean, it's to go from a Medicare Advantage plan to a Gap plan can be easier. Sorry, to go from a gap plan to an advantage plan is generally easier, but to go from an advantage plan to a gap plan, it's not that it's impossible at all. It can just mean there's more hurdles that need to be have to jump through. So my viewpoint is as you're enrolling into Medicare and making these decisions, that's when you want to work with really trustworthy folks like Kevin and his team that are going to help you understand the pros and cons of both directions and make the best decision to start. So that way there aren't any other challenges later. Again, it's not impossible. I helped an advisor who was working with a client in Louisiana. The mother was in Florida. Mother got a cancer diagnosis, wanted to get off her Medicare Advantage plan and go to a Gap plan. She was still able to do that even though there was this now known health issue, but it did increase her gap plan premium. It still wound up being a cost savings overall for her. And it allowed her more flexibility to also have a standalone Part D plan. So it's not that it's impossible, but it can be more challenging. And I don't know. I try to make things as easy as possible.
Yeah. No, that's interesting you use that as an example, because that was the exact
Mm,
example, different states, but
mhm.
similar type thing where they wanted to go to a specific provider who wasn't in their Advantage network. And then, of course, you hear different things, right? I also hear things from friends, family, neighbors that say this is how this works. So they mentioned they were able to do it, but it was a one-time life only. So if they would ever switch off the Gap and go back to Medicare, then that's it. Is that a fair statement, or
Mm,
for the
I
most
would
part?
For the most part, I think,
Okay.
Kevin, maybe you have some more functional experience doing this. But for the most part, yeah.
No, Grant, I mean, I think you're correct. Typically, to move from a supplement or a gap plan to an advantage plan is relatively easy, just because there's no medical underwriting with an advantage
Yeah.
plan or anything along that line. The opposite is kind of also true because you're moving to that supplement plan outside of your guaranteed uh, acceptance period or guaranteed issue period. You could be subject to medical underwriting. Rates could increase. They could tell you no. We do it, I don't want to say all the time, but we've helped people do it. It like everything else with Medicare, it's a one-to-one decision every time that happens. So very much an individual case-by-case basis.
Okay. All right. That's everything that I had on my list. So thank you guys for kind of itching that scratch that I had. As we talk there for a little bit longer, does anybody else have any other questions? All right. So if you guys have any questions, Kevin has his resources there. If anybody has any questions for Graham, email me and I can see what sort of information I can get relayed back to you. Again, Kevin is a local resource who's boots on the ground, actually providing coverage. I think is a great starting spot there as well. So thank you both for your time this evening, sharing it with me, sharing it with our clients here at Feldmeyer Financial Group. If there's anything else, let us know. Otherwise, I'll give everybody the rest of their evening back. So thank you all.
Thanks
Thank
for
you so
having us.
much.
Appreciate
Have
it,
a wonderful
Derek.
evening.
Good to see you
Take care.
guys. Thank you.
Yep. Thanks, guys. Take care.
Bye-bye now.